Hello, my name is Haane Massarotti. I am a colon and rectal surgeon with AdventHealth Medical Group. I practice primarily at AdventHealth Tampa, and thank you again for joining me for the CME. Today I will be talking about anal cancer screening. So, anal cancer screening and prevention. This talk will give every practitioner, whether you are a primary physician, a gastroenterologist, a colorectal surgeon, or a surgeon of any other type, overview of who needs screening and how to do it, and more importantly, why should we do it. I have no relevant disclosures. A couple things: I was not formally trained to perform HRA and learned this throughout my time as a colorectal surgeon during my attending years. So this is something that I picked up as a passion, and it's something I have dove into head first through the last few years. I'm definitely not an expert on anal cancer screening and look to other experts, but this is something that like I said, I'm interested and excited about. After this talk, you should be able to review the risk factors for anal cancer and AIN, discuss the relationship between AIN, HPV, and anal cancer, and present a simple clinical algorithm for screening for anal cancer. Let's talk about this. First of all, anal cancer screening. This is probably the first time you've ever heard of such a thing. What is this? Well, there's a lot of barriers to even beginning the discussion, let alone the practice of anal cancer screening. From a patient standpoint, as you know, talking about the bottom is something a lot of patients don't want to do for whether it's social, cultural, environmental, or personal reasons. From a provider standpoint, there's really a lack of training. You know, we as physicians and as colorectal surgeons actually don't get specific training or education on anal cancer screening that's very focused, as colorectal training, even within its subspecialty, is a broad field. A survey of colorectal surgeons done through the ACRS showed that only 1/3 of them had performed anal cytology and 1/3 had performed a high-resolution anoscopy. The colorectal surgeons that are more likely to screen are women, recent graduates, and surgeons who work with HIV patients. Like I said, there's very little data on the education of colorectal surgeons, but this is a very specific field, and it's something that I have taken hold of. From a societal standpoint, there's a lot of stigmas about talking about anything related to the anus, let alone cancer, and then the combination of the two. So really quickly, anatomy. The anal canal definition is from the dentate line all the way to the anal verge, where it's longer in males. The focus of anal cancer development is really in the anal canal epithelium. Proximal to this, anal canal epithelium, it's normal columnar epithelium of the rectum, and distal this is normal skin. So it's this transition zone, which is also called the anal transition zone or the squamomucosal junction. So those are two different words that you'll hear when it comes to the area that we're focused on. Distal to the anal verge, it's normal skin. So this is a picture looking at color-coded regions of anatomy. So the anal, when we say anal lesions, it's if you were to spread a patient's buttocks, you would not be able to see it. Perianal is anything directly around the anus, and then anything beyond this in basically the ischial fossa, or for layman's terms, the butt cheek, it would be SCC or skin cancer. So quickly, anal cancer is not as prevalent as colorectal cancer, so there's not a lot of it in the press. It is rising, though, at a rate of 2.9% a year, and the reason for this is HIV patients tend to be the patients that have the highest incidence of anal cancer, and HIV patients are living much longer now with the newer drugs. It is the 27th most common cancer in the US as compared to colorectal cancer, which is the 3rd. And it's about 0.5% of all new cancers and a very small percentage of all cancer deaths. So while not common, it is rising and is something that doesn't have many providers that are interested in. So this is why talking about this is important. Most of them are caused by HPV virus. Once again, anal squamous cell cancer is more common in women, and is also more likely to develop in homosexual males or men who have sex with men. The highest rates are in HIV positive homosexual males. So this is a population where if you have a high incidence or if you take care of HIV positive patients, you are more likely to identify precancerous and cancerous lesions. I have some numbers there. I'm not going to read them off to you. So what are the risk factors for anal cancer? So persistent HPV infection is the big one in HIV. There are other ones listed there. One of the more important ones are the history of cervical, vaginal, or vulvar cancer, high frequency of sexual intercourse and number of partners. But from a clinical and practical standpoint, while I don't ask all these questions, I do specifically pay attention to a history of prior cervical, vaginal, or vulvar pre-cancer pathology or cancerous pathology, and obviously a history of HIV infection and immunosuppression. Microbiology. HPV is a double-stranded non-enveloped DNA virus. There are multiple types of HPV viruses. The high-risk ones are listed here. There's about 10 of them, but the ones we really worry about are 16, 18, 31, 33, 45, and 52. There are low-risk types of HPV, and those are 6 and 11, and those are more associated with condyloma and AIN or precancerous lesions. I have a couple slides there on mechanism of action if it's something that you're interested in. Of note, HPV is also the etiology of oropharyngeal cancer. So this is a flow chart or a pathophysiology chart based on the cervical cancer data, which we have drawn a lot of the data for anal cancer from cervical cancer. As we know, cervical cancer was a public health success story given the high, the widespread use of screening for cervical cancer with pap smears, and women were less likely to die of cervical cancer because of this. So we sort of extrapolated this data to apply to anal cancer, although it's not, there's a lot that's not known, which I'll go through here. But basically what this slide is saying is that if a patient has HPV virus and their body's immune system isn't able to suppress it, if it stays around long enough, then a patient will get precancerous and cancerous lesions of the anus. There are vaccines recommended by the CDC. The most recent one is Gardasil 9. Ideally, it's given before sexual activity. It was approved by the FDA for males and females ages 27 to 45 in 2018. And there is a list of who and when to give it. Now, this is something that is usually managed by an infectious disease doctor or a pediatrician. And it's something that I don't personally do. It doesn't mean I'm never going to do it, but it is important as a healthcare provider that you are aware that there is a vaccine for it. This slide, I know it's complicated, but it was out of the Lancet, and it basically, the question is, well, how many people out there have HPV? On the left is overall prevalence. So the most important thing is that HIV status is the most important determinant of how prevalent the HPV is. So if you look on the left, where it's normal, the prevalence of HPV in a HIV negative female is about 40%. But an HIV positive male, it is upwards of 80%. So all this graph shows is that HIV prevalence or HIV status is the most important determinant of prevalence. This is also a complex slide. There's not a lot of data, but I've tried to compile it. Another thing, 2 other determinants of HPV status is sexual orientation and HIV status. So if a patient is sexually active and a homosexual male, they're more likely to have HPV. Sexually active women who are HIV negative, the range is varied, but any HPV, it's about 56%. So that would be your healthy female who walks in without HIV for any other reason. They have more than a 50% chance of having any HPV and up to a 36% chance of having high-risk HPV. And like I said, the data is sparse and the quality is not high-tiered or high-level. However, this is what we do know about it. Also a busy slide, but what's important is the association between HPV prevalence and anal neoplasia. So on the left is men and on the right is woman. The HPV prevalence of a HPV 16 HIV negative male is 80%. So it's high. And on the right is woman, it's even higher, so it's 90%. But the most important things that I have circled here is those circled patients have high risk HPV, so HPV 16 and 18. Once again, similar to that couple slides ago about cervical neoplasia, there is a progression. It's not that all of a sudden the patient has normal skin and then there's cancer. And what this talk is focusing on is catching the HPV infection status and the precancerous status, therefore interrupting the pathway or flow to cancer. So the question is HPV really the only thing needed for anal cancer? Well, no, but the determinants of HPV persistence and the progression are not understood. So it takes more than just HPV status. There are other environmental and patient factors that are responsible. We just don't know these factors completely. So let's talk about some definitions and terminology. So pre-invasive lesions or precancerous lesions. The World Health Organization uses the terms AIN or anal intraepithelial neoplasia, where AIN 1 is low grade and 2 and 3 are high grade. So 1 is low grade, 2 and 3 is high grade. There's other terms you may hear, a squamous intraepithelial lesion, which is endorsed by multiple societies, where low grade SIL is basically equivalent to AIN 1 and high grade is equivalent to AIN 2 and 3. So once again, historically we used to use AIN, but currently you'll hear terms such as L-gain, L-cell, H-cell, H-gain, and this is basically what we're talking about. And of course, invasive cancer, oftentimes terms will be anal cancer, anal squamous cell cancer, but anal cancer in itself is assumed to be squamous cell unless the word adenocarcinoma is listed. But once again, don't assume anything. This is actually, I made this flow chart about the relationship between all three, where on the left is your HPV type, subtypes, and on the right is whether you have a precancerous or a cancerous lesion. As you can see, there's multiple pathways to getting cancer, and we don't know if patients get anal cancer because they've had low-grade lesions or high-grade lesions, or if they go directly from HPV to cancer. That might be the case, but we don't have the technology to determine it. So there's a lot we don't know. In the middle, I wrote ASCUS, which refers to anal pap smear. So atypical cells of unknown significance, which will make sense in a couple slides. So once a patient gets a high-grade lesion, how long does it take for them to actually progress to cancer? And I get asked this all the time by my patients. And we don't know, but 12% of patients at 18 months will progress from AIN 1, which is low grade, to AIN 3, which is high grade. And there's another study that came out with the end of, with 550 patients, where patients progress from either ASCUS or low grade to high grade. 25% of them progress in 36 months. So we really, really don't know. There's just not a lot of data. But once again, since many of the low grade strains are caused by low risk HPV, the risk of progression to high grade dysplasia carcinoma has thought to have been lower. So I know that's a lot of work, but we don't worry so much about the low grade lesions. It is the high grade lesions that we worry about. And they're not necessarily related. So what about the progression, not from low to high grade, but from high grade to cancer? So once again, low quality data. It could take, in an immunocompetent patient. So this is, a woman who comes in who's otherwise healthy, who had a high grade lesion on their anal pap smear. She's like, otherwise has no risk factors. Like, am I going to get cancer, doctor? Well, you have 11% chance of getting cancer at 9 years. So it's low and it takes a long time. And that's, the benefit of having a good quality anal cancer screening program, at least an understanding of who needs to be screened, because you have the ability, we as healthcare providers have the ability to prevent cancer, completely prevent cancer, since it's so slow growing. In HIV positive MSM male, so the homosexual male, associated with progression are listed there, but basically male having erosion or ulceration, and the other things associated with poor outcomes with HIV, including low CD4 count, smoking, and other HPV type infections. And one important thing there is their progression is higher, so up to 18%, and it would take 2 to 5 years. So there's a large population cohort study looking at, and this is recent, looking at the progression from high-grade lesions to anal cancer in the HIV positive MSM population, which is, by the way, the most studied population when it comes to anal cancer. And the median time to progression is 24 months with no predictors of progression. So 33 out of about 600 patients did get squamous cell cancer. There are a bunch of other studies out there. The data is varied. I'm not going to go through all of this, but as you can see, the populations in these studies are usually mixed with a wide variety of number of patients. Their parameters are all different. So, and the ways of evaluating the rate of progression are also all varied. So, like I said, data is not good, and this is what we do know. So how do we screen it? So there's clinical. Well, most patients are asymptomatic, so there's really, you can't, there's no real clinical way to diagnose a precancerous lesion. What I will see is an incidental finding after hemorrhoid. So a patient will have a hemorrhoidectomy by another colorectal surgeon or a general surgeon, or get a biopsy of the hemorrhoid by a gastroenterologist, or even a dermatologist, and there will be an incidental finding. There's 3 ways to screen: DRE, digital rectal exam, anal pap smear, and high resolution anoscopy with biopsies, which I'll talk about. Anal cytology or an anal pap smear is an office-based procedure. We use a thin prep solution at the same time with the same kit. HPV can be tested as long as you put it on your order. And most labs will reflex test, but once again, you have to be particular with your lab. It's been a trial and error for me, and I have finally found a lab from an outpatient setting that I've been able to work with. Your outcomes for an anal pap are going to be one of the following, and I tell patients this: the study, either the sample wasn't good enough, it was negative, we don't know, or somewhere in between. And so these are the listed results. Now there is a way to do anal cytology. It's simple. You simply place the probe or the brush into the anus, into the anal canal, about 4 centimeters in, before any lube has been applied, and you make sure you place the brush against the anal transition zone, and you circle it for about 3 or 4 times, and then you put the tip of the brush into the thin prep solution, break off the brush, and that's your specimen. High resolution anoscopy is another procedure. I tell patients it's similar to a colposcopy or a LEEP or an in-office procedure, and these are is more applicable for females who have had in-office procedures, but it's basically a procedure where the squamous columnar junction is evaluated with magnification. Acetic acid and lugal solution are applied. Acetic acid is essentially vinegar on steroids, essentially, to get rid of the mucus, plus the lugal solution to allow for coloration of potentially precancerous lesions. There's a gross description of the lesion to suggest metaplasia, and biopsies are taken. This is done, this is my sample note, so I actually prescribe the patient Valium, which I'll prescribe a one-time dose. I will make sure they have someone driving them at the office. And I also do a local pudendal nerve block, so that most patients are comfortable with this, and I am able to accomplish this successfully in the office. There's a meta-analysis of how sensitive and specific is this. Once again, data is all over the place. So for low grade and high grade in the bottom right, in the HIV negative homosexual population, it's 88 to 98%. So the sensitivity and specificity is all over the place. So for all patients, for detecting cancer, these are the patients who got an anal cytology and then went on to either get an HRA or surgery. Was the anal cytology or the pap smear, same thing, able to pick it up, and that's what we're looking at here. So it just depends on the population. So it's high in the MSM population, high in the HIV positive population, but in all other populations, we really don't know. Here's another study looking at the same thing. So looking at detection of high-grade lesions or cancer, it's as high as 91, a sensitivity and specificity of 91% for all patients. Sensitivity of 91% for all patients, 95% for all patients. So that's fairly high, but the specificity is low. Once again, how accurate? This is a study out of the DCR in 2019, looking at cytology versus histopathology, looking at 34 studies, and the pool sensitivity and specificity is 85%, 43%, where this study was looking at the detection of anything greater than IAN2 versus AN1 or normal, and this is higher in the HIV population only. Let me see here. Higher in the HIV positive MSM and MSM patient population only. So this study is better for the HIV positive and MSM population. So in summary, this is a list of all the different ways of screening. And on the right, I have boxed high-res anoscopy as the gold standard diagnosis. You know, it's only available in highly selective centers, and we are proud to offer it at AdventHealth Tampa, or have a medical group associated with Tampa. The learning curve, we don't really know. It is second line after a pap smear. The professional societies, what do they have to say about this? Where it's all over the place. So the American Society of Colorectal Surgeon actually doesn't really make a recommendation to screen the general population nor high-risk individuals, and do recommend the anal pap smear and HRA. You know, but as you can see, I'm not going to go through all of these. There's really no consensus, and this I think is due to a lack of data and a lack of understanding, and also all the reasons I talked about in the beginning of our barriers to patients obtaining adequate care. The colorectal surgeon said, American Society of Colorectal Surgeons says that the anal pap smear exam is only a recommendation based on low-grade quality evidence. So once again, not good evidence. But in summary, based on my knowledge of this topic and reviewing all the societies, and I'll put a list of all societies that I have gathered information from at the end for your information. Any HIV positive male, any HIV positive patient with condyloma, any HIV positive female, any homosexual male, women who have had precancerous lesions or cancerous lesions, women with condyloma, and anyone with solid organ transplant recipients or other forms of immunosuppression. So, you know, rheumatoid arthritis, Crohn's disease on immunosuppression, psoriatic arthritis on immunosuppression, and we do get a lot of these patients coming in. This is my algorithm. There are a couple algorithms out there. UCSF has a good one. Stephen Goldstone is a big name in this topic, but I have created my own algorithm based on scientific data that I have gathered and critically evaluated. And basically, when a patient comes in, one of the first things I ask is their sexual orientation and their HIV status, and then I go from there. But those are the two determining factors. Whether or not they get the HRA anal pap, as you can see, for example, a homosexual male who is HIV negative, you can offer them an anal pap, but you sort of have to assess the situation. Are they anxious about it? Are they worried about it? Have they heard about it? And both are reasonable. You just have to have a full discussion of the risks and benefits and what you're trying to achieve with the test. In general, however, you know, anyone who's HIV positive, as you see, should really go straight to an HRA. That's what we do know. Once again, these are the UCSF guidelines. This was published at Cleveland Clinic, Florida. And this is actually a really important slide because one of the biggest determinants of whether or not you proceed to an HRA is if on an anal pap smear, a patient has, let's say they have, it's, you know, ASCUS, which is very, you know, atypical cells adenosiniphans, and negative for HPV, I'm talking about high-risk HPV, you don't necessarily have to go straight to HRA. And this piece, this HPV piece is really, really important to making that determination of whether you want to do a high-resolution anoscopy. And that is based on newer data. There is a, you know, a push for doing HPV alone as a screening tool, given the high, you know, the relationship between the HPV virus, high risk, and precancerous lesions. This is a retrospective single center data review. All patients had anal cytology, HPV testing, a DRE, and an HRA. And in conclusion, they found that once they, like I previously stated, the high-risk HPV testing improves the specificity and positive predictive value over cytology alone for anal cancer. This is their proposed, this is based on this study. You know, this is Stephen Goldstone out of Sinai up in New York, who publishes a lot on this topic. Based on this knowledge of the high role of high-risk HPV, this was their new anal cancer screening algorithm, which just came out recently. So earlier this year, late last year, where if the patient has ASCUS but negative for high-risk HPV, you can consider repeating cytology in up to a year. So in summary, why should we do this? Why should we screen for this? It's simple and available. Anal cancer, once a patient gets anal cancer, the treatment is chemotherapy and radiation for most patients. So we can prevent patients from ever having to get to this point. At the same token, if a patient has a localized versus metastasized anal cancer, their survival has a significant spread. So 30% versus 81%. And we have an ability to impact the patient's outcomes if we can catch any lesion before they become cancer. The incidence is rising. Patients are living longer with HIV. Really, the only preventative method is abstinence, and that's almost nearly impossible in this society. Anal cancer is often diagnosed late because of the barriers, which I mentioned earlier. So patients think they're hemorrhoids, providers, physicians thinks, oh, I just have hemorrhoids. It's just a little something, and then before you know, they have cancer. And once again, cervical cancer has been a public health success story. So it's something that we should be doing. And that's all I have. So hopefully you've taken away from this talk the importance of screening for anal cancer, who should you screen, how to do it, beginning with either an anal pap smear and HPV for most patients, and considering HRA in the HIV positive patient. And an HRA is simple and available and a minor office procedure that we can get good data from. Here are some resources. The biggest ones are IANS and the American Society for Colposcopy and Cervical Pathology. They do have their own journal. There was an upcoming course in San Francisco for basic HRA. I'm not sure if it's going to happen with everything going on, but it is for formal training. If anyone's interested, they're great resources. Thank you very much.